Okay. Good morning, everyone. Welcome. Thank you. Welcome, and thank you for coming to how we see the role of SBHCs in practice and payment reform. We have 4 panelists I'd like to introduce. First of all, my name is Paula Hester. I'm from the Oregon School-Based Health Alliance. We officially haven't changed our names, but we're working on it here with the national office. Our 4 panelists today are Serina Reckling, here first on my left. She's the policy analyst at NASBHC and has been tracking the state's implementation of primary care medical home policies and programs. Jessie White-Frese is sitting next to her, and she is my cohort in Connecticut as the executive director of the Connecticut Association of School-Based Health Centers. And along with her association colleagues, has been the leading advocate and champions for SBHCs to be included in Connecticut's primary person-centered primary care practices. Iliana Kiourkas, I think I should know how to say that, but is also at NASBHC and has been supporting technical assistance and training strategies to support SBHCs in the model of care. And Kate Conway, the director of school-based and community health program for Henry Ford Health Systems in Detroit, Michigan, has been instrumental in involving one of her sponsored SBHCs in the medical home certification pilot program under the Accreditation Association for Ambulatory Health Care. You will hear that later probably as the AAHC. We just want to set, first of all, I'll let you know the restrooms are down at the end of the hall and around to the left. So if you need to slide out, please do so. During our session today, we're going to have about a 50-minute panel discussion, but you have note cards. And on those note cards are nothing, so we want to see you fill them up. We wanted to give you the opportunity to ask questions because we're going to do a QA at the end of the session, or for the last 25 minutes of the session, so we only have plenty of time for that. So as we go through the panel discussion, we're going to start off with some policy discussion, and then we're going to talk about some practice that's going on. And so we want to give you the opportunity to ask questions, and we don't want you to forget what those are. And some of you are as old as I am in this room, and I know what it means to try to remember things. So I just want to share just a tiny little story because we all believe stories should happen when we are talking about things. About 40-some years ago, I was a youngster, and I was swinging with both arms, had pushed myself up between a couch and a chair and was swinging my legs between them. You know how little kids do that and how much they like it? Well, my arms slipped off the couch and I caught my head right here above my eye. And it was a Sunday night, and I was bleeding like mad. You know how heads bleed. So my parents called our family physician, met him at his office, and he stitched me a nice K on my head, which I think may have been a predictor for having worked with Terry Wright at Kellogg's some future time, but branded. But my point being that was the kind of health care that many of us remember. You call your physician, and I have a great-grandfather who was family practice and made house calls. So this tradition of wanting to have person-centered medical home is definitely something that we feel is seated in the roots of our country. And so I'm eager for us to talk about where this potential model is going, or this practice is going, as we all institute it across the country. Excuse me. My water's over there. I would also just like to point out that I am the parent of a 30-year-old that has multiple disabilities. And Jonathan is, one of those folks that bring a lot of joy to my life, and probably has taught me more than I ever knew before I met him. But as a partaker of the Medicaid program for many, many years, I can also tell you that managing that care has been kind of a tremendous effort. And so I think the more that we can help folks think about the person and their needs will bring significant help and hope to families as they manage interesting set of circumstances that they may have, the capacity to take on advocacy for themselves in healthcare programs. And so with that, I'm going to go to my little moderator seat over here. And as I do that, though, I'm going to, slides. I forgot my slides. It's a good thing Serina's here. Okay, so these are our presenters, and we have no relationships to disclose. We all live in different states, so we're not related. I'm just kidding. These are our objectives, which you have in your booklets, and we know that the triple aim kind of drives this whole concept of patient-centered medical home. Triple aim is healthy population, extraordinary patient care, and responsible cost, or reasonable cost. And I think that it's interesting that all of these lend themselves to the things that we all worked for in SBHCs, which is an upstream approach, that we have measurable outcomes and we are prevention focused. So there are key elements in the medical home model: access, care coordination, and management, comprehensive services. There will be a test, so you might want to write these down. And why is access such a great part of this, and why can we always put a check beside that? It's because these services are located where the young folks are, and they have that opportunity to receive care. SBHCs have been coordinating care for kids for a long time. Am I right? Yes. Okay. I like it when I'm right. And then comprehensive services, we definitely know that there are SBHCs that provide primary care. We know in California some of those SBHCs provide just mental health services. However, we ideally have seen this program grow over the last 20, 30 years and have seen a mixture of those services in our SBHCs. And then there's clinical quality measures that's a component of the measure of the medical home. And SBHCs are already engaged in quality improvement measures, specifically under CHIPRA. Patient and family engagement, youth and parents are actively members of the community. And you know, we have a lot of, I had a person mention the other day that they thought that youth were involved in SBHC just for the sake of having youth involvement. But they heard some stories that helped them understand that they actually are helping drive the quality of services within their community. And then, of course, these are community-based. Where else do we have a central hub other than the schools? So now we're going to move on to some policy and practice questions to give you an opportunity to listen to our panel and then to open the floor up to some of you. So I'm going to start with our first question, which will go to Serina and Jesse. And what is the patient-centered, what is the trend in the development of state primary care medical home policies and programs, and are SBHCs included?
Great question. So as you guys know, the concept of patient-centered medical home has been around for quite a few years now, but states are really starting to implement a lot of patient-centered medical home programs through their Medicaid agencies because there are a lot of incentives in the Affordable Care Act. So because states are in charge of creating these programs, they vary greatly state by state. Some states have passed legislation requiring Medicaid agencies to develop patient-centered medical home programs and payment models. And other states, they're just starting to kind of implement and work with some pilot programs. So currently, there are three kind of main trends that are happening in terms of patient-centered medical home development. First, states are endorsing patient-centered medical home criteria established by leading national accreditation agencies such as the National Committee on Quality Assurance, also known as NCQA. So NCQA is a nonprofit organization that's really been involved heavily in quality improvement here in the nation. And they have really been the leading agency in developing and implementing a patient-centered medical home program. And as a result, most states have kind of just really endorsed NCQA standards and used it as a model, more so than other agencies that have kind of started developing patient-centered medical home criteria after NCQA, such as the accreditation agency of, I messed it up, the National Association, how was it? The AAHC and the Joint Commission. And Connecticut is an example of a state that has endorsed patient-centered medical home criteria. So they are basically requiring that if any Medicaid provider that would like to become a patient-centered medical home for the state of Connecticut, they have to reach level 2 or level 3 patient-centered medical home recognition by NCQA. And level 2 and level 3 is intermediate to advanced patient-centered medical home level. And in addition to reaching level 2 or level 3 recognition by NCQA, these practices are also required to meet certain state criteria, an example of which would be to participate in local or state public health initiatives. And the great thing about Connecticut, and Jesse will be talking about this more, is that in Connecticut's patient-centered medical home policies, they clearly define school-based health centers as an eligible provider as long as they are able to provide access to primary care services all year round, which may be an issue for smaller school-based health centers. The second state trend is that states have established their own patient-centered medical home criteria. And that is an example of the Oregon Health Authority. So they have created their own criteria which have been developed around 6 key elements of patient-centered medical home, and that's access, accountability, comprehensive whole person care, continuity, coordination and integration, and person and family centeredness. So Oregon is really kind of leading right now in terms of really reforming how healthcare is delivered for their Medicaid population. And they are requiring all of their Medicaid participants to receive healthcare services from a network of providers that are part of a coordinated care organization. And a coordinated care organization are newly formed local and regional networks of payers that are basically responsible for providing care for the Medicaid population within a given global budget. And state law requires that these coordinated care organizations include patient-centered primary care homes in their networks. And therefore, the state of Oregon is strongly encouraging that school-based health centers become certified through the state as a patient-centered primary care home. And then the third trend that's happening is that states are requiring their contracted managed care plans to implement patient-centered medical home programs for their Medicaid population. So Louisiana is an example that has contracted with 5 managed care plans to manage the health care for its Medicaid population. And as a condition, these health plans will be required to provide the necessary technical support to help their providers meet the patient-centered medical home criteria for either NCQA or the Joint Commission. So in the next 3 years, these managed care plans will have to make sure that a certain percentage of their providers become certified through the Joint Commission or NCQA, or they will not receive a renewed contract with the state. And the great thing also is that the managed care plans are required in these policies to offer contracts to school-based health centers if they meet certain criteria. So, and as these programs are developing, the Medicaid agencies are also, developing different reimbursement payment methodologies to reward the patient-centered medical home providers. And there's also 3 different trends in accomplishing this. The first is that the Medicaid agencies are offering per member per month coordination fees in addition to regular fee-for-service. And a second option is that some states have decided to offer an enhanced Medicaid payment rate specifically for the services provided by the patient-centered medical home. Sometimes it's for all services, sometimes it's for a handful of primary care services. And then the third trend is that a lot of states are implementing pay-for-performance programs. And an example of that would be in Connecticut, which is planning on implementing a pay-for-performance incentive program in which they will evaluate a core set of pediatric and adult measures that the providers are required to submit to the state. In addition, they will be reviewing EHR records to ensure that they are patient-centered medical home compliant. They will then review these two main indicators and will rank each practice from highest to lowest based on these indicators. And all the practices that fall within the top 3 percentiles will receive an additional incentive payment. And that about sums it up. Thank you.
Thanks, Serina. Jesse, can you tell us what effective and ineffective strategies there were in approaching advocacy for SBHCs in Connecticut's plan?
Sure, thank you. And Serina, you did such a great job that I can really just dive into, I think, the practical elements of what we did in Connecticut to get ourselves involved, to be a voice, to be part of the discussions that were happening, because I don't know, had we not really advocated for ourselves and really gotten involved, if we would necessarily be involved to the degree we are today. So I think that is something I would certainly say as a message from a practical point of view, is that if you are not in any way involved in these discussions in your state, that you begin to find out where the discussions are happening and how can you become involved in them. Things are moving along very quickly, and it's already time to be having your voice from school-based health centers be heard. So some strategies that we used to ensure that we could be involved in the implementation process. A while back in 2011, early 2011, and even prior to that, that we had several of our board members, and some of our board members for our association are school-based health center directors. So some of us had already been involved in some statewide committees. And we have a Medicaid Oversight Assistance Council that oversees the Medicaid program, for instance. It's been active for many, many years. It has legislators and many types of advocates involved, as well as the managed care companies at the time. And so we had a member appointed to that commission. So we were always aware of what was going on in Medicaid. There were also some other ad hoc, so to speak, programs, task forces happening. We had a member that was on that committee. So very involved already in paying attention to what was happening in Medicaid and being involved in whatever developments were occurring. So that's when there was a pilot program in Connecticut that they called Primary Care Case Management. It was put out to private practitioners. And the goal and the hope of the state Medicaid agency is that they would get a lot of providers to sign on and be involved and adopt this model. It was not terribly successful. And so back to the drawing board, what could be done? Meanwhile, on the federal level, more was developing in terms of the person-centered medical home. In the spring of 2011, our association really ramped up our involvement in these committees because we began to feel like if we don't get involved now, we're going to be out of the picture completely, and we were really worried about that. So several of our members went on and joined some specific committees that were part of this implementation process. And one of the things I do want to say about our state Medicaid agency is that they made a decision to get a lot of input as this was developing from many sectors in healthcare. And it was, I think, a very wise move and has turned out to be a very successful move in that they created a transparent process. They really listened to what people had to say about the practicality of implementing all of these things. So there was a provider advisory group, and we have 2 of our association members that sit on that because they both happen to be providers. I sat on the Care Coordination Committee, and although there was not much discussion about school-based health centers, in all of those committees, we injected, don't forget about school-based health centers, whenever we could. And we really looked at what were the strengths that we already had, and both Paul and Serina talked about that a little bit, in that we feel as though care coordination is something that is inherent in the school-based health center model. We've done it for many, many years, and we understand it better than many private practices do. And we think that that is really one of our shining examples, along with the fact that we have a comprehensive model. And that comprehensive model means that in Connecticut, there are mental health services always co-located with medical services. How many private medical provider offices have that? Not many. Some programs have dental. It's all right there, and it's much easier to coordinate with community providers and that sort of thing. So simultaneously, we had some legislation in 2011 that deemed nurse practitioners eligible to become primary care providers for the first time. That was brilliant because we have, so obviously, nurse practitioners, for the most part, working in school-based health centers, so it was another rung on the ladder that we were able to climb. We had a new governor that was elected. He appointed new commissioners in all of the departments, and those commissioners, in many cases, either were not terribly familiar with school-based health centers or had never seen one. So we decided a strategy was to bring the commissioner of the Department of Social Services out to a school-based health center for a tour. So we did that in the summer, last summer, 2011, and that was a very, very good move because, as you all know, when someone sees a school-based health center, they really get it and they understand. And we were able to bring providers around the table, and we were able to talk with him about our strengths in school-based health centers. We then went on and met with the Director of Medical Care Administration, Dr. Mark Schaefer. And again, we really pointed out the strengths. So I will say that what we did was we developed some key message points. And we just kept repeating those everywhere that we went. Because what we keep getting back, well, how are you going to meet the 24/7, 365, requirement? And some of our school-based health centers have electronic health records, some are in the process, and some will have a struggle with getting them and implementing them because of their sponsoring organization. Doesn't mean that they won't, it just means it won't be as easy for them as some others. So our key messages were, school-based health centers are seasoned providers of comprehensive, coordinated care. For many, many children, we are the usual source of care. They may identify a primary care provider by name on the enrollment form when they enroll in the school-based health center. But that doesn't mean that they ever go. And certainly because of access and convenience, students tend to use the school-based health center certainly far more than they go to their primary care provider. So that was another one of our messages, that we were a usual source of care. And I think I would say in some ways we repeated that message so much that began to be a discussion in some of these statewide committees. So that was really important. And so there were draft regulations that came out in December of 2011. And I'll read just to you the quote because we were very excited that we made it into the draft regulations. And it said that outpatient clinics enrolled in the Connecticut Medical Assistance Program, which may include a school-based health center, where the school-based health center meets all the requirements of the PCMH program, including, but not limited to, the requirements to provide year-round access to primary care services. So in some ways, we felt like we'd arrived. We were actually named as an entity in the regulations, and we felt that that was really important in the result of our work. So I think it shows that you really can make headway. So I'll just wrap it up by saying currently there are, in our entire state person-centered medical home initiative, there are 9 practices that have been approved by the state, and those 9 and these are not school-based health centers exclusively. There are other types of providers, FQHCs, large group medical practices, and that sort of thing. So there are 92 sites, practice sites, with 378 providers. There are many other organizations in pending status. And I will just say one thing very quickly. We developed something kind of interesting. I don't know if other states have this term or this process, but they developed something called a glide path. I don't know if people have heard that. And it always makes me think of ice skating for some reason. But a glide path is that you can register and enroll and enter in, but you have parameters of time in which you must accomplish certain criteria in order to continue to the next step toward what Serina mentioned was the NCQA level 2 or 3 recognition. So some school-based health centers have entered into the glide path, and there's currently are some FQHCs at the moment that have begun to enroll their school-based health centers as person-centered medical homes. So it's a work in progress, but I think there's some practical strategies that you can take to really make sure that you're part of the conversation and ultimately an eligible provider. You're welcome.
All right, so we're going to turn to a little bit of the practice, and I heard over here a question about that 24/7, 365, and we're going to come back and touch on that a little bit more in a minute, but don't let us lose that question, okay? So I would like to know, Iliana, if you could tell us about the 2 practice sites that worked with NASBHC and the AAAHA or C or, one of those other alphabet organizations. Give us an idea of what went on there.
Sure, thanks, Paula. So just to give a little background, over the past year, NASBHC's programmatic team, we've been trying to develop a training and technical assistance plan for school-based health centers, given the emphasis on the patient-centered medical home. And what we've been doing is we've been trying to do a lot of research in terms of how they fit that, this model of care. And we started off by doing some key informant interviews with some state association leaders for our school-based health center associations, as well as representatives from those various recognition programs, as well as state-led entities such as the Oregon Health Authority. And in addition, we were trying to find out what were the standards that states were using. As Serina alluded to earlier, the states are the ones that really decide what standards are to be used to recognize practices as medical homes. And so what we found was, in the beginning, NCQA was the dominant player, and for a couple of reasons. They've already had a medical home recognition program for several years now. And in 2011, they released some revised guidelines for their medical home recognition program. So we started thinking about, what our ultimate goal was that we wanted to be able to help school-based health centers become medical homes, become nationally recognized as medical homes, and also help them assess their readiness of what they need to do to achieve that standard. So we started, through these interviews, through our research, we launched our webpage, which houses the state policy information, as well as information about these various recognition programs, and as well as some toolkits that would help us, that practices can use to assess their readiness. And in December of 2011, we actually had representatives from NCQA present a webinar to our field about their standards for their recognition program. And even though they had they provided a very detailed overview of what their standards were, a lot of the participants that were listening or viewed the webinar felt that they didn't quite know how the school-based health center would align with those standards. So there was a lot of questions that still needed to be asked. So again, we were kind of feeling like we haven't been able to find concrete answers in terms of what does it take for a school-based health center to be nationally recognized as a medical home, either by NCQA or by other entities. So we actually had an opportunity to partner with the Accreditation Association for Ambulatory Healthcare, which is also known as AAAHC. It was actually random at another national conference last year. Representatives from that organization, they spoke with our Director of Programs and Professional Services, Laura Bray, and they informed her of an on-site certification pilot for medical home that they were going to be conducting. And AAAHC, they actually accredit ambulatory care settings such as health centers, medical and dental group practices. But this pilot program would allow practices, including school-based health centers, to undergo the certification pilot without having to apply for the more rigorous accreditation program. And we felt that this type of participating in this pilot would give school-based health centers a voice and be part of something, be proactive as part of a pilot to really have the chance to be nationally recognized as a medical home. So they mentioned that they would allow 2 school-based health centers, not programs, but actual sites, to participate in this program. And so what NASBHC did is that we reached out to our state school-based health center associations, and we asked them for their suggestions of who they felt would be, which sites they felt would be the most poised or ready to try to undergo this process. And so we had 5 school-based health center sites from 4 states express interest, and that was Connecticut, Florida, Michigan, and North Carolina. And they basically provided some information, some background information about who they're sponsored by, what type of staffing model they have, if they have an EHR in place, also if they're open year-round. And those summary sheets were forwarded to the Assistant Director of Accreditation Services at AAAHC. And ultimately, upon reviewing them, they suggested the 2 sites that they wanted to participate in this pilot program, one of which is Pioneer School-Based Health Center that's sponsored by Henry Ford Health Systems. And basically, and the other one was Silver Lane Elementary School, School-Based Health Center in East Hartford, Connecticut. So the on-site certification pilot includes an online survey that the site must submit. And in addition, what's different from other certification programs is that there is an actual survey visit to the school-based health center. So in March, both of the 2 school-based health centers, they did submit their online application to AAAHC. And then within about 30 to 45 days later, an on-site visit was scheduled with a regional surveyor from AAAHC to visit the school-based health center to really identify and build on that initial online application to see where they are in the continuum of being a medical home under their particular standards. And in early May, we had a regional surveyor come out to Pioneer School-Based Health Center in Detroit at Detroit Edison Public Academy. And during that site visit, the site visit was a full day and included a tour of the school-based health center, interviewing a lot of the staff, the clinical staff, as well as the administrative staff of the program, doing some chart audits, and also many discussions about how the school-based health center operates, what services they provide to the children and adolescents, and also just ideas about how they know they are the medical home for their students. You know, what evidence do they have? So it was a lot of in-depth discussion with the surveyor and the school-based health center administrative staff. And basically the next step would be that the surveyor would draft recommendations or how they feel the school-based health center is aligning with the standards of AAAHC, and also where they need some recommendations of where they need to work on in order to be an optimal patient-centered medical home for their students. And the next, if their recommendations are approved by the review committee of AAAHC, then the site would be a certified medical home, which would last for 3 years under AAAHC standards. So that's pretty much the background of what we've been researching over the past year at NASBHC about these medical home programs, recognition programs, and also how we kind of came about to this pilot program with AAAHC and 2 school-based health centers.
Thanks, Iliana. Kate, there must have been some nuances in the application process and the site visit that you hadn't thought about. So what was your learning as you went through this?
Well, the application was quite extensive, and in fact there were several pieces of it that was very hard for me as a program within a very, very large health system to be able to respond to it. So we had to make some adjustments because they wanted things like your name of your board of trustees and your audit report and such, that. So there were some things that we had to do. I think we went into it first. I was a little unsure that we would be in a good position to do this, which was actually the reason I wanted to apply, because I like to see these kinds of things as a way to, improve what your services are. In Michigan, our school-based health centers, if you receive funding from the state, are required to be open all year round. But of course, we are not required to be open 365 and 24/7. So that is the piece that made us a little bit anxious, although being as part of a large system, there is a way to work that kind of thing out with the hospitals and, on-call and that sort of thing. We are not yet totally electronic with our medical records. That was the other element that kind of made me feel like we might not be able to qualify for that, although we are in the process of moving to the EPIC electronic medical record system. And the school-based health centers are on the schedule, and they are treating us like they often do, which is if you haven't been in one, you don't know what it is. And so they think it's going to be, they don't want to put you on the JCO list. They think you're going to make everything, you're going to make their process even less effective. But until they get in there, and then they realize we have the same physicians, the same nurse practitioners, medical assistants, everyone who's in that school-based health center is the same person who is working in the hospital or working at one of our ambulatory sites. Same certification, same requirements. And so that kind of thing, made everybody feel a little bit better. I think the other thing, and Jesse mentioned this, is where else can a child go to get primary care, behavioral health, dental, vision? I mean, we do the whole thing. Most our pediatric ambulatory sites, they don't have behavioral health. They have to refer that child out. And then in many cases, we, even though we may not be the assigned primary care provider for that child on that card, we really are, as all of you know, that this is where the children end up coming. And so we end up doing that kind of coordination of the care anyway, just as a natural part of what we do. And so I think when the surveyors came, they not only saw a clinic that would meet every JCO requirement in terms of its construction and ADA access and such like that, they also saw that this was high quality, the same quality of care that a child would get if they walked into one of our ambulatory sites, and that has been our mission all along. And so I think in some ways I was a little anxious, thinking, oh geez, are we going to meet these requirements? And I think in the end, the surveyor and the others said, you're actually in a better position than you think you are. And the other thing that we have taken from that is we've decided to work with one of the larger Medicaid HMOs in the Detroit area, and been working very closely with them, and we've given them zip codes of where our centers are, and they've given us names of kids who, first of all, are assigned to the Henry Ford system because we're an employed physician medical group, and then be able to dig down deeper to say these are the kids you have who haven't seen a primary care provider in 2 years. And then a little deeper to that to say, okay, these are also the kids who we know have have asthma, for example. And so we are targeting those specific kids in those zip codes. And we really think that being able to use that as sort of the launching point for this medical home will really help us to, secure the credibility and the certification. My institution has chosen not to do the NCQA certification. They are doing something else called PGIP, which comes through Blue Cross, which doesn't always help the school-based health centers because we see some Blue Cross patients, but not a whole lot. And then they're also participating in a primary care transformation project. But it is a constant battle to say, we're over here and we do the same quality work as you might be able to do in any other site. So,
is there anything else you want to talk about in terms of successes or barriers that folks might want to know about?
The EMR is probably the biggest barrier because we really want to be able to show that the kids in the school-based health centers who might also see another provider, specifically within our health system, that the primary care doctor out at one of our ambulatory sites is able to communicate with the pediatrician or the nurse practitioner in the school-based site for a child who maybe has a chronic illness, diabetes or something. And so they do that now, but the implementation of the EMR will make that a whole lot easier, very, very seamless. And so we're very anxious to get that in place, and it's not an easy task, actually.
So the biggest challenge was your your medical records, and I can attest that that's probably going to be a consistent statement as everybody goes to that process. Is there anything else that you guys want to share about the project itself?
Well, the main thing is this 24/7, 365, and I would urge, any group that is maybe not connected with a large system that can provide that support, is to make sure that you find that kind of support, whether it be, a small hospital or private practice or whatever, because that is you have to be doing that. And then we also will be able to do the enhanced reimbursement for the Medicaid, because we've required all of our providers to be part of on the staff, the faculty at the local university, and then that helps with that enhanced reimbursement.
Oh, that's good. That's good. So we're going to start taking your questions. Josh, are there folks that, can you hold your card up if you have a question? We're going to gather those. So if there's one particular thing that you have on there that you want to make sure gets answered, put a little asterisk by it. So we're going to try to filter through the questions a little bit, see which ones are alike, which ones are different sort of things. But while we're doing that, and I'm going to ask the rest of, I guess, Jesse, maybe you could talk a little bit more in the meantime about the 365 24/7 issue and the availability.
I just wanted to mention that there are some folks holding cards up over here, so that weren't collected for questions. So we've had some discussion about in Connecticut about how would our school-based health centers fulfill that, because we have different models in Connecticut of sponsoring organizations, as I think many states do. Some of our school-based health center programs are sponsored by health departments. Some are sponsored by boards of education, and they subcontract to community agencies for the clinical staff. Some are sponsored by FQHCs. Some are sponsored by community-based organizations, and so and hospitals. And so, depending upon that relationship, you may or may not currently already have that larger system, as Kate mentioned, to be able to build those, either build the relationships or build the continuity of care for times when the school-based health center is not open. In Connecticut, for the most part, for one thing, almost all of our school-based health centers are funded by the state. The majority are funded by the state. And there typically is not enough funding available to be able to stay open all summer. So that's been, that would certainly be perceived as a barrier that would need to be overcome. And some sites are beginning to be able to be open in the summer by deriving other income sources, but we're looking at strategies, perhaps, both short-term and long-term strategies to be able to meet those requirements. So certainly some would be to be able to find a way to obtain some additional funding, I mean, ideally from the state, but I think given our economic times that may not be possible at all. So how can sites find some other funding to be able to stay open during the summer? That would be one strategy. In Connecticut, all of the school-based health centers are required in their contracts, if they're funded by the state, to demonstrate what their 24/7, 365 coverage is. So some sites have contracted with a private medical provider. Sometimes that person might be the school medical director, or might just be contracted as a medical director for the school-based health center program. So one possibility would be to develop some sort of a contractual relationship with that private provider who would accept your patients at times that you weren't open. The only catch on that, I recently learned, is that provider also needs to be moving toward achieving NCQA recognition. So that, might be a challenge, and maybe it isn't. I think there'll be many different scenarios that will happen in Connecticut on how people will achieve this requirement.
Okay, thank you.
You're welcome.
I have one more question about the 24-hour, 7-day-a-week. Does a 24-hour nurse advice line fulfill that requirement?
It could, but at least in our institution, we had done that several years ago and really felt that they wanted to keep to the provider having, so people rotate that coverage. But then with the emergency rooms available and urgent care centers and everything, that's where that coverage comes from. But it's my understanding it could.
Yeah. And that might even get into what accreditation program that you use. And so I think you have to pay attention. So whoever answers that question, it'll be probably based within the scope of accreditation certifications. Okay. One question that came in is, why have providers be a part of faculty at a local university? I think, Kate, you brought that up.
Yeah, at least in our state, that allows them to have that enhanced reimbursement. And what they've done at the local university is they restrict the number of providers that they will take in, and they also will take students. And so that's the way that we've structured it in our area, is that they're on the staff of the university.
So I'm going to ask you to go a little deeper on that. If they're on the staff of the university, what kind of university are we talking about?
It's a Wayne State University.
Right.
It's a medical school.
It's a medical school. So, yeah. It made me think about, and I hadn't explored this until we were just talking about it now. What about services on site at universities where there's a student health center? Is that an access point that is going to be available for kids when?
I think it depends on the university.
Yeah.
I think some of them do have a student health clinic. We aren't, involved with that specifically, although we are talking with one local university who would like to be able to have sort of a first choice access to one of our ambulatory sites.
Okay, good. How do you meet the challenge of SBHCs as patient-centered primary care homes when insurance coverage is carried by a separate agency? There's no EHR records to share.
Well, in Michigan, we're not required to have contracts with managed care organizations. We can bill the managed care organizations without a contract and without prior authorization. That is a good thing in one sense. Not that we get paid every time we bill, but
is that familiar to anyone?
Yes. Yeah. But on the other hand, it keeps you outside of the system. So you still get into this situation where there's how we treat kids, and then there's school-based health centers, and that's the dilemma that we all have to be aware of. That it needs to be, the way we treat kids needs to be inclusive of, as opposed to having the school-based health centers be over here. It's not like how we really see kids. So that's why, even though that policy has allowed us over the years to bill, it is not the policy that's going to move us forward with being able to provide to the plans, data to meet their HEDIS measures and immunizations and stuff. So we're trying to take. That's why we're doing this pilot with one, managed care plan and 3 zip codes in the area to show that we can actually help them with their HEDIS measures, because they still treat us as kind of
out there. Yeah. Did you want to add anything to that, Jess?
Well, I would just say that in Connecticut, for many years, the school-based health centers have been able to bill and have been. In 1996, Connecticut moved to a managed care process, and all of the school-based health centers were required to enroll in the managed care organizations that serve their area, and in the managed care contracts for all of the companies that were doing business in Connecticut for the Medicaid program, they also were required to contract with the school-based health centers. And that was all very new, difficult at the time. There were 11 managed care plans, and so we had to contract with all of them. Over the years, they dwindled down to 4 and then 3. But we just moved this past January, simultaneous with the implementation of the person-centered medical home initiative and the ability to enroll in it, we moved away from managed care after all these years to a single administrative services organization.
Wow.
One of the benefits of that is that that particular organization that won the contract was in place all of the time from 1996 until now, and their only product line is Medicaid. They are not a commercial insurer. And so I think they had a much better understanding of school-based health centers because they'd been involved with them and because they also understood the whole care coordination process. They, in fact, have a unit that they've either newly developed or expanded where they have specific workers that are working on practice transformation, and they'll work with you one-on-one to really help you. I've had some calls from them, and they're very excited about school-based health centers being involved. They recognize the challenges, but what they have also presented is that they want to do everything they can to help you get past that.
Right. So let's do a little defining here. There's some questions here about enhanced reimbursement, and the question is typically when you get your patient-centered medical home status, and you have a patient that fits within the criteria of that, and you are that person's provider, you would be getting that supplemental payment. In addition to which, you would be getting you would bill for the subsequent work that went along with that. So you're getting that minimum $20 or $30 or $90 or $100 payment to be basically the medical home. And the question has come up is how do I position myself to get enhanced payments? So now I'm kind of thinking, are we talking about the difference between, so maybe this could get clarified from whoever asked this question, are we talking about the difference between getting the supplemental payment in terms of being the primary care home provider for this person versus the enhanced payment that comes along with meaningful use? Mm-hmm. So who asked this question about, I don't want to make anyone feel bad. Does everyone understand the difference between those two? As a primary care home, I have a person assigned to me, I may get a supplemental payment. If I want, if I meet meaningful use standards under Medicaid, I get those meaningful use enhanced payments. So those are two separate things. Correct. And don't necessarily, but correct me, tie together. I don't have to be the medical home for that person in order to get an enhanced payment. Is that correct or is that wrong? Anyone?
I think
that may vary.
I see them as two different things. The meaningful use dollars are related to the EMR and go directly to the provider. Mm-hmm. You have to apply and everything goes to the provider over the course of a few years. The enhanced payment, it is my understanding that in the Affordable Care Act, even if it is struck down, that there is provisions in there that at least for 2 years, Medicaid payments will be made at the Medicare rate, which is slightly higher than what we get from Medicaid.
Right.
That's my understanding of what's sort of in the law at this point. Even though, and I believe that if something happens with the Supreme Court, that still will go in place at least for 2 years. Mm-hmm.
Okay.
And I don't know that is connected to being a medical home.
Okay. Iliana, did you want to add to that?
I was going to say that the incentive payments for meaningful use it's a set dollar amount and it's broken down per year over the course of 6 years. That's completely separate from the per member per month enhanced reimbursement because the per member per month varies according to what the state delegates would be the reimbursement structure. So those are two separate entities.
And John Schlitt, did you want to add?
I wanted to qualify on the enhanced payment because they are largely made for physician practice only. So if you are affiliated with a clinic or a FQHC, you would not qualify for the enhanced rate as we understand it. It's primarily for physicians who are primary care practices that aren't associated with a larger clinic service. So there's some very specific criteria around who qualifies for the enhanced payment. But there are some states that are attaching an enhanced reimbursement rate. This is completely different. If you qualify as the patient of a medical home, it's different from the monthly per member per month. That's usually $2, $3, $5 per month. So it's slightly different, but in some instances they're just adding a few extra dollars to the payment that you get for a particular service, if that makes sense. So it's different state by state.
Okay, thank you, John. So we have a lot of questions around and let me see if I can field a few of these at once. Is healthcare reform pushing SBHCs out of a necessity to become part of a larger healthcare system like FQHCs, hospital systems, in order to serve as a model of healthcare delivery? I think I can tell you that there's a part of logic that says when you have a broader set of assets to take on billing and reimbursement and administration, then certainly there is a benefit driven that way. However, nationally, I think we're still at about 60% that are non-FQHC associated. Is that correct?
For school-based health.
For school-based health centers. And in the state of Oregon, it's just the opposite. We have 60% that are FQHC associated. And there are certainly driving numbers that show that the reimbursement goes up under those centers, et cetera. Whether or not the answer directly is yes, it's pushing it that way, I think there will be, so we've certainly already seen in our state people become certified as person-centered primary care homes without being a part of an FQHC system. So it's kind of I don't think that that healthcare reform has made that situation any different, really. I think you get the perks or the disbenefits. There's also a question about they're all coming so quickly. I want to make sure I've got the right one. There was a question about my SBHC is a satellite of an FQHC, which is a level 3 person-centered medical home. The SBHC was not included in the application and did not certify. How can I convince my organization to include the SBHCs in certification? Anyone? Anyone at all?
Well, I think that the short answer on that, I think, is that when I think about this whole process that's happening, one of the things that occurs to me, and I think Iliana pointed out, it was pretty clear when we had the webinar with NCQA, no one was thinking about school-based health centers or this model of care when this was developed. This was developed as a physician practice-driven model. And because there were not those other kinds of services immediately available and coordinated through those practices as a medical home. So I feel like in many ways, school-based health centers are an afterthought in a train that was already rolling. And that's why I'm saying to you that I think it's really important that you get involved now if you're not already. I also understand, I mean, I personally have not gone through the process, but I also understand that, firstly, one of the things that an organization such as an FQHC would be interested in is getting accredited by NCQA if that's the standard in their state. And anything that might slow that process down or compromise the ability to get that recognition initially, because it's site-specific, I would think that they would not want to undertake. That would make sense. And I think that although we have pointed out today, and I'm sure many of you are aware of the fact that we bring so many enhancements to the concept of a medical home that you might not see in other places, that the structure of the school-based health center has not been thought through as being part of this model. So It's not quite the square peg in the round hole kind of situation, but it's still, I think, an afterthought. And so I think what we're seeing in Connecticut, I don't know if that question came from Connecticut or not, but is that now as FQHCs that have already achieved recognition are submitting for additional sites, they are now beginning to include their school-based health centers. I know from the most recent Medicaid care coordination meeting that I was at, care management meeting, is that there are 3 school-based health center sites in one of our communities that have put in their application because they're part of an FQHC to become recognized. So I think it will happen over time. And in terms of convincing the organization, I think it goes back to what Kate said. If your organization's JACO accredited, for instance, as an FQHC, then your school-based health center should be up to all those standards as part of the organization. If you are, you probably have less to worry about than you think, as Kate pointed out, if there are consistent standards and practices. And so convincing, might depend where your organization is in the process, but they can continue to apply for you at any point.
So we have a couple of questions around the cost of accreditation through AAA, and
this doesn't stick.
and NCQA, and anybody have a specific answer? Iliana?
For NCQA, I believe, please correct me if I'm wrong, I believe it's $500 per clinician that is involved in the application process. And for the AAA-HC pilot, the cost per site that underwent under the pilot program, now this is not, we don't know how it's going to be when they have the official rollout, but it was $1,000 per site.
And are there ongoing costs once you've received accreditation?
To my knowledge, I'm not sure.
Only if you want to reapply to go to a higher level.
Okay. Yeah. So you'll go in as tier whatever, and you want to reapply and go up a tier because you've gotten such and such. Okay.
We should add that a lot of FQHCs receive money from the Bureau of Primary Care that are paying those application fees, part of a national program. So that's one thing to check with your FQHC.
Okay. All right.
I wanted to add to something that the previous question that Jesse answered. Unfortunately, we've heard stories of larger organizations that left out school-based health centers when they applied for medical home recognition. And a lot of the reasons why that we were told were that the school-based health centers the sponsor felt that they would not qualify under the standards for whatever reason, and that it would be costly to bring on those additional sites, those school-based health center sites, because a lot of the recognition programs are either per clinician or per site. So unfortunately, we have heard stories about that the school-based health centers being left out when the larger sponsoring organization applied for recognition.
Okay.
That is actually often a problem, and it's a misperception. And that's why the education, even in an institution where I work, which is very supportive of what we do, we still have to constantly remind people that this is real care of children. This is not just, patting them on the head. And the only way to do that, and we've been talking about this for the last 2 days, is to quantify what you're doing, to be able to show the value added to their program, not just in the community benefit area, but also in the areas of keeping kids out of the hospital, keeping them well, and that sort of thing. You really have to just take that very business-minded approach.
I think another thing to add to this is, and this is whether you're in Oregon, they have set the standards, and it's really making the case, and they align a lot with the NCQA standards. The good thing is it doesn't cost you $500 to make applications. So, and our primary care office there is really working. They did we had a summit in our state, and folks came together, including the primary care sites. We had John out. We had several SBHCs there to kind of walk through the practice material, self-assessment material that they had. And I think what was really beneficial of having a state-driven project was the primary care office was able to hear where the challenges were for our SBHCs, be they FQHC sponsored or not. And that, will help drive kind of the iterations over time. I can tell you that most of our SBHCs applying are already finding they meet Tier 2. We were certain everybody could meet Tier 1. So I think that should give you some kind of a hope to go back and be assured that you've got a lot of it already in place. The pieces that aren't in place are not impossible. And we've got a provider and that is having probably more to do than everybody else in the state, and she is really moving her practice towards this model, and I have to applaud that. There's someone here that's asked the question in CQA. They wrote it really big. Thanks. Requires that the SBHC is providing primary care to 75% of the population. How can SBHCs meet that requirement? I'm going to suggest that maybe this is a little inside out. Anybody want to clarify that it's 75% of the population?
And who defines the population?
Yeah, and
Your clinic population.
Yes.
That's how I understand it.
So could that be the kids in the school or the kids and their siblings?
Yeah, they're just wanting you to sign an agreement that you're honestly saying that when you submit for recognition, that your school-based health center and the providers there are providing primary care to 75% of your clinic population.
So taking into account that it's open to all.
Right.
Yeah.
I mean, you define your clinic population
However you want.
I just wanted to see how our folks working on this are approaching.
So one strategy I've heard is that you should be looking at your encounter and claims data and really just, look at the encounter data and be like, look, these kids are coming in here all the time. And look, this percentage of kids, they come here 2, 3, 4 times a year. And we're constantly doing this work. So that's a suggestion that was made. And I've heard that in Oregon. In fact, Oregon is determining who the PCMA is by looking at the encounter data. Yeah. And so based on, this SBHC really is the patient-centered medical home, regardless of what the card says, so they're going to get the enhanced rate. So I think looking at your encounter data and really doing the math and really seeing and, improving that you really are the PCP for this percentage, and hopefully it is 75%. Yeah.
I can add to that. Thank you. Spurt of thought is that one of the things that we've been told by this single administrative services organization I described before is that after several months, and it will be somewhere between 3 and 6 months, they will run some claims data, and they will be looking at where patients are getting most of their care, and if they have named so and so as their primary care provider, but they're having multiple visits and none of them are there at that primary care provider, they're at the school-based health center or some other location, then what they are proposing now is that then that usual source of care, I don't know if every state is really focusing on that term or not, but that's something that we are focusing on in
love it.
Connecticut.
I'm taking it home with me.
Yeah, it's really good, and it really makes sense for school-based health centers. So that usual source of care could then be assigned as the medical home, assuming that then the school-based health center has become the medical home.
We have 5 minutes. I've got a couple of more questions. I did want to point out, too, the other thing that we have as a strength is that, given that the services that we provide are very population-based, that it's a very significant population that is not typically being seen, as you're working with your medical sponsor, if it's an FQHC that basically has ignored the opportunity to include you in their application, you need to bring the numbers to them. You need to be able to show them the data that helps their cause to be showing the outcomes for what's happening specifically in this population. And so I would suggest that be one of the things you think about. So a couple of other things that have been asked, and these are going to be our last questions. one is wanting an example of working with practices or the providers to successfully manage patients that receive compensation for the practice thinking this is from the SBHC and the SBHC. I don't know who asked this question. We might need some clarity. Any examples working with practices or other providers to successfully manage payments? Is this your card?
It's my card.
It's your card. Could you just clarify a little bit on this?
My question really is around successful models of working with practices and sharing patients back and forth, and both groups receiving payment for it. And trying to augment services in one place or the other, depending on where the patient's seeking the most care. And I think it's an important topic as we move towards accountable care and global payment and how school-based health centers fit into that moving forward.
That is a great question, and we are trying to collect your stories, and we've been emailing all of our members to try to get SBHCs or providers to come forward and really share with us at what's happening at the ground level. So I would encourage anyone here or anyone listening to really contact us at NASBHC, because we want to hear what's going on and we want to share best practices. And his question on how they work together and how the payment reimbursement works, that's a great question, and we would love to hear if anyone is working on that. And a lot of this is still in development, so I don't think we'll really have a full understanding how this is all working, especially with the financial incentives, until probably a year or so from now. But we are at NASBHC tracking this and trying to understand what's happening. And as we find out these best practices and learn more, we will definitely be sharing that with our members.
And in the short run, I can tell you our CCO in Oregon doesn't actually go into practice for another month or so. But one of the things is that whether the child has a primary care home someplace else and is seen at the SBHC, both can bill the CCO for payment. It's just that the patient-centered primary care home is the one that receives the per member per month payment in addition. And they probably received an enhanced payment for that service as well. So does that make sense? Okay. And again, I'm going to make sure they have all of these questions, because maybe we'll do an FAQ on that site and give us all the opportunity as things come up to mail them in and say, okay, we need the answer to this. So this is going to be an ongoing process. I just want to quickly hit on, have all states endorsed accrediting agencies such as CQA and AAAHC? And the answer is?
The answer is no.
Yeah.
It varies. Okay. So I passed out a little handout that kind of gave a little snapshot of different states and what they're doing. And it really depends. I mean, some states are focusing more on the exchanges and haven't really worked on the patient-centered medical home programs. But on our NASBHC website, I have created some fact sheets of the states that kind of have a program in place now. So I'd encourage you to go to NASBHC.org and check out the state fact sheets. I mean, not every state is working on this now, but there are a handful of states, and I have provided a fact sheet. And if any of you have questions about your specific state, feel free to contact me, and I can help you look in the right direction and help you find out what you would like to know more.
And as a reminder, that's Serina.
Yeah, this is Serina.
Yeah, not of California, but of the School-Based Health Alliance. So thank you for your time and being here. I thank our panelists for their bright minds and their very well-prepared information. Thank you all for being here and for supplying the questions, and we hope you have a great rest of the day.